to start before we move along. There we go. You can start when you're ready.
Yes, ma'am. Okay. Go to the first slide. I'm Dr. Anthony DeQueer, a podiatrist in Baton Rouge. I've been in practice in Louisiana for about 20 years. And so I'm just going to give you a basic interview, I guess, overview of what diabetic foot care is like for me. Most importantly, like the first slide, is prevention. So you can, I tell patients, even at home, do not walk barefoot because, again, around every corner, there's always something can happen like that. Toothpicks, thumbtacks, earring backs, happens all the time. Even outside like that process, the beach like that being the case, it tells them to wear aqua socks because, again, on the beach, broken glass like that happens all the time, spines. I went to the beach recently, almost stepped on a stingray. I'm like, okay, wear shoes all the time. So again, even myself, healthy person like that, wear shoes. The biggest part right there is a risk assessment. So again, if you see a patient like that with diabetes, whether they're healthy or not, look at their feet like that process there. Look for any digital deformities, hammer toes, bunions, any pressure points, because again, those are all precursors for breakdown. And so again, a patient like that being the case, he has a risk right on the left on the side on the screen there, risk assessment. And so again, when you're seeing a patient with diabetes, evaluate their neuropathy level like that process there, and the sensation in their feet. Sometimes you maybe a shades of gray like that. So for one time you see them on January, they may be fine, but throughout the course of their career, like that process there, that may have slowing of their sensation like that process and gradually over time lose sensation. That being the case, it's important to check regularly because again, a patient may think they're doing fine one day, but then they have no sensation in their feet, they don't have any pain, so they keep walking, and then one day their foot has an ulceration or a sore there. So again, assessing risk assessment like that process is look for deformities, hammer toes and bunions for sure, but also any pressure points, because again, a plantar pressure point, they use dorsal pressure point with the hammer toes too, from like a tight soled shoe there, or a tight shoe itself, a tight toe box is important. Presence of ingrown toenails or presence of any abrasions or sores, all are important for overall health for the foot. So again, right here, you can see on the bottom of the screen there, they have a hammer toes are basically dorsal contraction of the toe like that. So what happens, rubbing the shoe, the top of the toe across here, rubbing that shoe there, the shoe's not a deep enough toe box, it causes pressure. And again, ulceration or at least a corn can form there. Bunion across here is a wide foot across that area there. So a wide shoe is important for that structural deformity there. And so next slide. And so again, with respect to shoe gear, you want a nice deep shoe like that process, depth laid shoe. Most shoes themselves are pretty comfortable, but again, patient has a hammer toe or bunion, requires increased pressure like that, increased pressure reduction or increased depth in the shoe. So again, diabetic shoes themselves afford to the patient increased depth like that, decreased pressure points, decreased risk for infection, decreased risk for breakdown. Orthotic insoles is important as well plantarly because again, not just for pressure reduction, but also for support, because the patient walks like that with a plantar pressure across that area there. Also, that pressure is important to prevent any ulceration or breakdown. Also prevents pain. As far as padding, those little gel toe tubes like that process or gel cushioning. Non-medicated pads are important because again, medicated pads are made of acid, tend to cause pain, tend to cause burning of the skin, irritation, and also breakdown. So again, non-medicated pads are important. As far as stretching, a patient with a hammer toe, stretching makes the foot become more flexible there. So again, a rigid deformity becomes more flexible over time, reduces plantar pressure, reduces pressure on the shoe, and gets them to walk better. And obviously, the last thing we want to do is like that surgery on a patient with diabetes. But again, the patient has a pressure point in the foot like that and can't resolve it with stretching and padding. Intervention with surgical intervention may be helpful, make that rigid hammer toe into a more flexible hammer toe there, make it flat, and make it reduce that pressure. And so again, next slide. This is an example of a shoe like that. This is our shoes we have on the side here, Dr. Comfort shoes. But again, there are different types out there. And the shoe should be a nice deep toe box across there. So again, you can see the top of that shoe like that. The toe itself is not touching the shoe because pressure, especially with the patient with neuropathy, leads to breakdown, leads to ulcerations and problems. So again, shoe gear is probably the most important aspect because again, protects you from having pain, but also protects you from having trauma and keeps you walking well. And so the next one for right across here, here's an example of orthotics basics. Orthotics in the past were designed more so for support, like for people with heel pain or for tendon pain. But again, for patients with diabetes, I find it's more with a nice soft insole across there, accommodation insole, for support that's for pressure reduction like that. So again, you can see the right top of the right screen there. This metatarsal has a little metatarsal pad there, which also the pressure point to the metatarsal head. So when they're walking, there's less pressure under the ball of the foot, basically. That's a common area for calluses to form and also ulcerations to occur as well. On the bottom of the screen here, you can see for patients with amputations, whether it be loss of all the toes across the metatarsal heads across here gone, or just a ray, you can put a toe filler there to help make them walk better. And with the same size shoes, so again, it's not like they're wearing a special shoe that process there. but also makes them have better ambulation. You can walk without the toes, although the push off like that process decrease, so it makes their gait a little bit different. So they can walk, but obviously their gaits change. Next slide. And so when the patient does form an ulceration, unfortunately, the two different systems always used for that process there, Wagner and also University of Texas. I did my training at University of Texas 20 years ago, so again, for UT, Wagner's classification system itself deals mainly with depth of the ulceration itself, which, attacks deep like that process, deep structures, whereas UT system encompasses depth, but also encompasses ischemia, which is PAD or peripheral arterial disease, as well as infection. So again, the combination of the depth as well as the other mobility of that process there, to me, gives you a better grade of what to expect long-term wise and also what to expect as far as healing. So next slide. This is a study right here compared to two systems there. And again, it just basically shows that University of Texas system itself, classification system itself, shows a better outcome as far as that process there, better assessment of outcome. And it's better what to expect long-term wise as far as healing ulcerations and also preventing amputation itself. Because again, you can predict depth of wound, which is what's important, but more importantly, presence of infection, also the presence of ischemia or lack of adequate perfusion of the arterioles like that process there. So next, this is a patient I saw. Next slide. Next, I saw last the slide before that. Patient I saw in clinic last Thursday. I see him pretty often, but again, he missed a visit. So again, we were probably a month behind where we normally see. You see on the right foot across here, the left side of the slide, he has a rigid cavus foot, which is a hard foot across there. Lots of calcification sub second metatarsal head and sub fifth, which in the right foot itself always had the same process there, but doesn't really break down. The left foot, you always in the sub second metatarsal head there, always has ulceration or preulcerative lesion there. By him missing that visit, it made the calcium itself thicker, and unfortunately led to an ulceration. So again, right now he's currently waiting for orthotics like that for orthotics. He already had diabetic shoes, and also waiting for a consultation with the vascular surgeon as well, because again, he sees him pretty often, but again, now an ulceration is forming there. So now at this point in time, he needs increased perfusion to help make that wound heal. And so he'll be followed up closely with vascular podiatry, infenology, as well as his primary care doctor, make sure he has the best outcome for healing, as well as x-rays as well, to make sure there's no underlying infection present in the bone there. And so you can see the next slide here. This slide basically shows when ulceration occurs like that process there, the risk for amputation is definitely increased. And so again, when ulceration forms, the risk for another ulceration occur is also increased as well. And unfortunately, contralateral ulceration can occur as well with that process there. And so again, the most important aspect is preventing ulceration. So again, obviously patients that walk on nails like this process here, but walking out without back to that first slide there, walking without protective shoe gear there, go back one slide. Yes, ma'am. Walking without protective shoe gear, again, basically you're playing with your feet across this process here, because again, that's fine. Any type of pressure across that area there can cause problems. So again, it makes it become tender, makes it risk for ulceration and breakdown. So again, the most important aspect is prevention with that process there. Because once the ulceration forms, we're pretty much chasing our tail as far as getting to heal. But avoiding injuries across the process in the first place helps patients stay healthy long-term wise, keeps them active, keeps them ambulating well, and also decrease risk for further problems down the line. So next slide, right across here. So again, obviously we can't walk in bubble wrap all day long or a coat of armor there, but obviously diabetic shoe gear like that process there, orthotic insoles, also in pressure, and also tell patients regularly inspect their feet with the mirror if they can't see their feet pretty well like that process there, because again, avoiding injury, avoiding pressure points, noting any risk spots there or abrasions is important in a big picture for preventing ulcerations and infection like that. Because unfortunately, pressure leads to ulceration to amputation. At that point, quality of life suffers. So again, avoiding injuries, avoiding pressure, keeps the feet healthy, wrap them bubble wrap, and keeps them healthy and going forward. And so any questions? Next question.
Just gonna jump in and say thank you.
Yes, ma'am.
We love your lecture, and obviously for this patient today, definitely this is, we need to clarify this as well and add this to the list of things we were talking about. So, you know, prevention seems to be the way to go, and we just need to do the best we can. So thank you so much. This is a great lecture. You know, when the patients come with so many questions and issues and things that we need to address, I think a lot of us skip this part, and I think it's super important. Like you said, this is their independence, they're walking, driving and everything else. So thank you very much. And anybody has any questions or comments for Dr. DeCure?
Yeah, I think a multifaceted approach is important too. So podiatry, endocrinology, medicine, vascular, orthopedics, all those guys are important because again, it takes a village to raise a child like that. Same thing with diabetic patients as well to continue to heal. When alteration occurs, like that process there for sure, orthopedics, podiatry, vascular, all those guys are important because again, no one factor by itself gets the wound to heal. So all those things come together in a multidisciplinary approach and it works well like that being the case for the patient's long-term health and well-being.
Absolutely.
I have a question for you.
Yes.
As far as orthopedic shoes or diabetic shoes,
Yes, ma'am.
is that something that do you find is readily covered by insurance and
Actually,
Medicare?
Medicare, Medicaid, and all the private insurances all have a diabetic shoe program like that process. So once a year, the patient can get one pair of shoes and also a few pairs of orthotic of the basics of the bilateral insoles there. And so most of the insurance like that process there go through a set of requirements for first that being the case there, but definitely they cover one pair per year. Medicare and Medicaid require the primary care doctor, endocrinology doctor to sign off on that process there. With private insurance, the podiatrist, orthopedic doctor, or endocrinologist can just order that. At that point, it goes through that process there. But they're definitely covered by the insurances, one pair per calendar year. It goes from January to December. Yes, ma'am.
I have a question. I often have to write prescriptions for my diabetic shoes for my patients. How do they typically get fitted whenever they're bringing them over to stores? Is it something that they?
Certain shoes still do that. I don't bet. I think in Louisiana, I think New Orleans, cantilever is a good spot over there. We do our own shoots at the office, at my office right now here. So I measure them myself personally and make sure the shoes fit themselves properly. But sometimes, again, podiatrists themselves, whether it be, in Baton Rouge itself, we have a place called Red Stick as well as Hanger Labs here, which do a great job with diabetic shoes as well. But most podiatrists' offices order their own shoes and also measure their own shoes too.
Dr. DeClaire,
Yes.
this is Linda. I have a question. What kind of guidance do you give diabetic patients? I know about the foot exam and all that, but I mean, say they wanted to soak their feet or make them feel warm or, whatever. What kind of guidance do you give your patients on that? Not with any open wounds or
Sure.
anything.
I'm not a big fan of soaking because again, soaking like that process that patients sometimes with neuropathy can't feel how hot the water is, so they may burn the thermal injury. But also the soaking itself makes the foot become macerated there, which makes it less supportive, less protective, and also more pliable and more risk for abrasions and for puncturing. So only thing I recommend people soaking is ingrown toenails. Everything else I tell them do not soak because again, soaking can cause a lot of problems as well in diabetic patients.
Okay.
Yes.
Dr. DeQueer, I had a question. I sometimes make recommendations for foot creams and things like that. And I wanted to know, is there an over-the-counter cream that you would suggest for a patient who may have some issues with their feet or diabetic patients?
As far as a pain cream or
A softening cream or something just to keep the foot more, not too moist, but,
I think over-the-counter creams work pretty well. Eucerin, Lubriderm, Suave, Curel, Jergens, Gold Bond, diabetic cream, all work pretty well.
Okay, thank you.
Definitely. Just use something basically. Because again, the feet become dry with diabetes, and so again, keeping moisturized, especially when it's hot outside too, they did go out as a crack and peel and make pictures there. So I mortgage twice a day, every day, but not between the toes. Between the toes, keep dry because again, maceration will lead to athlete's foot basically.
Thank you.
Yes, ma'am. Big thing I see also with patients, especially older patients, is they wear their shoes too long. Let's say, sir, your shoes are older than me. Please replace your shoes. I think I tell patients like tires on a car, so many miles in the shoes like that process. After a year or so, replace your shoes, get a new pair of shoes because again, they become less supportive, less protective, and also risk for pressure points like that being the case.
Excellent questions and practical advice. I mean, we see patients all day, every day, right? And everybody has these little questions that we don't want to give them the wrong answer, right? And of course, as providers, we are supposed to know everything about everything, right? So it's a little bit of a tough spot. Anyone else? Any last few questions or comments? Okay, excellent discussion, everyone. I do have one last question.
Yes, ma'am.
When any advice, I guess, are you having any issues getting the paperwork needed from primary care endocrinologists. I know that the process is kind of lengthy, where the primary care has to send in a note and an order for
Yeah.
shoes, and then you have to do an order for shoes, and then the company has to kind of
Right.
put it all together. I mean, it seems a little intense.
Yeah.
Any advice what we could do better? People who send patients to you, or we just want the shoes. What can we do to help?
Well, I get only with Medicare and Medicaid. With private insurance, it's not a problem, but Medicare and Medicaid requires sort of guidelines to be done first. And so, unfortunately, it's just a process of getting paperwork done in a timely fashion. That's probably the most important. I tell patients, if you want your shoes like that process, call your primary care doctor, call the doctor, podiatrist as well. Make sure that ball's not being dropped anywhere. Because again, there's a lot of different people involved. But the medicine doctor, the endocrinology doctor, podiatrist, the staff, the person on the fax machine. So again, maybe here to there, but again, A to B to C to D, like that process is a long process there. So again, make the patient call back and forth and just, okay, when it's done in timely fashion, be on top of the process as well. Call the office and make sure, every month or so, make sure that two forms being sent and being received,
Excellent. Yeah, that makes sense. I mean, just kind of stay on top of it, because it
Oh,
is.
sure.
I mean, I recently had to get a pair for a family member, and we have been waiting for like 4 months because
Right.
the primary care didn't add whatever they are supposed to add, or didn't fax the records. There was just so many issues. So I like that advice. Kind of stay on top of it. Whoever needs to get their part done, stay on top of them. So
Yes, ma'am.
excellent. Okay.
Yes.
Wonderful. Well, excellent session today. I really enjoyed this one so much to talk about, and wonderful practical advice. And so I hope you all enjoyed it as much as I did.